Thank you for inviting me to speak on this topic. So these are my disclosures. So we know that sexual dysfunction is the major functional outcome in prostate cancer treatments, dictating treatment quality of life, mental health outcomes, and treatment regret. Unfortunately, most research in this field does not focus on sexual and gender minority patients. They're essentially heterosexual patients that we see. In fact, we don't capture a lot of the sexual and gender minority data at all in cancer research. Less than 25% of cancer centers, for example, in a recent survey actually ask about sexual orientation. This is really interesting because 6 to 20% of men actually have sex with men in a global study. In UK, that's about 10% of men, and 0.5% of the UK population identify as gender other than the one dictated at birth. That means in the US, for example, there are at least 100,000 sexual and gender minority patients who are prostate cancer survivors. One of the issues with this research is there's a really lack of perceived relevance to understanding anything about sexual orientation. And this causes issues, obviously, with provision of care and provision of the right treatment. In fact, a survey of our colleagues, of oncologists, found that only 40% thought that this kind of data was actually relevant. What this means is that sexual and gender minority patients have huge difficulties in accessing care. These figures from the UK are actually very similar to figures produced in the US. About 16 to 20% of sexual minority patients have big difficulties in accessing public health care, and about nearly 40% of gender minority patients. Because of all these reasons, the NIH in the US has declared sexual and gender minority patients a health disparity population. So these are populations that have avoidable, preventable disparities in the health outcomes. And research from the NIH was meant to focus more on this area. The implication of this and the understanding of this is that this is going to be an evolving, bigger issue as we move along in our practices, because LGBT identification, self-identification has doubled across the world, in the US as well in the last 10 years. And there's a generational difference as well with Gen Z, about 25% identifying as LGBT. So what is sexual dysfunction like in an SGM population? Well, you have the similar things that Counsel mentioned, the normal erectile dysfunction, and ejaculation and things like that. But you also have problems with, for example, anoreceptive intercourse. You have problems with the neovagina. How often do you dilate the neovagina? You have things like role in sex, which you don't think about in heterosexual intercourse. You also have things like interaction with what we normally prescribe without even thinking, PDE5 inhibitors, and what the community take recreationally all the time, poppers, amyl nitrates. Okay. The issue is even worse and even more stark for the gender minority patients. They don't only have problems in understanding the sexual consequences, but diagnosis, treatment, lots of issues there. For example, biopsying through the rectum instead of the vagina, you might cause a rectovaginal fistula. There are all sorts of problems with neurovaginal stenosis after treatment of prostate cancer, whether it's radiotherapy or surgery. Surgery itself is very difficult because the prostate is often stuck to the neurovaginal canal, and you get problems with skin necrosis because essentially your penis skin is inverted to create a neurovaginal canal, and that is the problem when you give radiotherapy to the area. So there are lots of challenges in SGM outcome research. We don't capture them. And the outcomes in the SGM population are also intersectional minorities, like ethnic minorities, is even worse. We know from lots of research that they have much poorer outcomes when it comes to palliative care outcomes, when it comes to mental health outcomes, end-of-life outcomes, and cancer outcomes. And we think from research as well, that this is a combination of a few things: faced discrimination, high-risk behaviors, the lack of social support. They don't have a family network that heterosexual couples tend to. And their partners face huge problems which are under-researched as well. So some of the goals of SGM research are to provide SGM patients and clinicians treating them with an evidence base and some tools to be able to manage these consequences of treatment, starting with the review of any current evidence we have, whether it's within prostate cancer or other cancers, and then looking at inclusive tools, engaging these patients in our research, trying to then create tools for the patients to understand the impacts of this research, to help them guide them through patient treatment choices, and also to help us as clinicians initiate these conversations. Current evidence review, that's what we did for Movember. I was part of the sexual and gender minority section of the review. There was not much out there, to be absolutely honest. About 30 papers for sexual and gender minorities before 2015, nothing before 2000, and about 30 since then. But this created the consensus statement, which emphasized the importance of initiating this conversation with patients. There are some more tips and more guidelines in the Movember document that might be useful if you want to start a program, a strategy for SGM patient care, but really with not much information in there. So what we're trying to do, well, first thing is we're trying to develop more inclusive assessment tools to understand what these impacts of treatment are. In fact, most of the assessment tools we use are extremely heteronormative, and most of them identify intercourse as explicitly vaginal penetration. None of them actually capture any anal intercourse outcomes. And we know as well that up to 30% of men actually engage in anal intercourse, and that's not captured at all. Okay. So just going to wrap up here, but what we looked at was an inclusive tool that was developed by the University of Minnesota. And this was validated in over 400 patients in the US against EPIC and found to be very acceptable. We actually used this tool in the UK in a London teaching hospital, again around 300 patients, to see if we could capture similar information and validate it against IAEF 15 and other continence measures. And it was absolutely valid, but more interestingly was the fact that it actually was very acceptable for all the patients. It was easy to understand. Patients were not offended by the questions. In fact, they just skipped the questions that were relevant to them. Our future work with Movember is going to involve looking at the whole of the UK, across the 4 nations in the UK, which have very different cultures, very different demographics, to see if this applies across the pond, basically. We're also developing resources for the SGM patients and for clinicians based on the outcomes of all this, collaborating with lots and lots of institutions from around the world. So that's it. Thank you.